chest tube.
Okay, so we've got chambers.
I remember this one.
This one actually is in reference to the, this one creates the underwater seal, right? Do we want to see bubbles in here? No. So what we would like to see is that, see this little bubble, this little ball here, what we would like to see is that it goes up and down with the patient's breath, so the ventilations, okay? If you see bubbles over here, you know that they've got a air leak. So that's not where you want to see it. But you do want to see some nice gentle bubbling over here because this is in reference to looking at that suctioning. It needs to be nice and gentle, not like it was when I first turned it on, okay? The other thing too is that if I have this on continuously, how would I even know? What could I do to find out if this level, and you always want to make sure that this one's got too much in it. It should be right down here. But how would we know if it was at the right level here since it's bubbling? All you want to do is just gently kink it. Okay, so it's not down to 20. What kind of fluid would I use?
Sterile water.
Good, yes. You do want to use sterile water on this. Okay, and you would put it into the back here. There's a special little thing that you can use, or you can actually use a sterile syringe to put the amount of sterile water in. Okay, and then you always want to put the cap back on. Okay, this over here, this is the chambers that's going to collect any kind of drainage that you have. And that's why, again, what you're always looking at is where it is. Again, it reads right along here. Do we ever want to put it up like this? No, we don't. We would like to keep it below the chest. Sometimes you'll see it hanging on the bedside. The other times that you will see is actually on the floor with the stand. And I'll be honest with you, I think I've done just about every stupid thing you could possibly do, including I had mine sitting at, and this was when they very first came out. We don't have them built quite that way anymore. And actually, I brought the bed down on top of it, and it split it right in half. It's like, oh, God. Just like we just intubated a patient, and that was before we had these, and did the taping and everything, and I wanted to clip the tape off, and I clipped the tape and clipped the balloon guide in half, too. So, you know, I will admit to some of I was human, and, you know, I did it, of course, luckily, he was an easy intubation. That was the good part. That was the only good part about it. So, again, but that doesn't usually happen. It's a rare, I've never, in the few years that I've been a nurse, and I can tell you how long, I've never had that happen again, and nor I never bring scissors near an ET tube anymore. So, anyway, so that is basically what we're looking for when we're looking at chest tubes, okay, in reference to chest tube. Managing those. Now, here's the next thing. What else do we want to know about in reference to our chest tubes if we're looking at where it's placed? We want to know where it's placed. Also, we want to know what's been noted about in reference to, although this is not... It's only because we haven't figured out how to get him to bubble and still. But what you also want to know is that in that dressing, do we want it on all four sides sealed? Or do we want one to be the lower flap? Yeah. Again. Do we clamp chest tubes?
Will we change it?
Okay. Yeah, when you're changing, you can clamp them. Do we clamp them very long? No, you don't. You have everything set up, and basically, and I've seen it where you pulled it off. You've got everything ready. You pull it off, you plug it in, and that's it. Okay.
So you don't clamp it.
You don't. Yeah. No. Even if you have chest tubes at the, sometimes at the foot of the bed you'll find the chest tube, the Kelly clamps. You don't clamp chest tubes. What happens if the tube pulls apart? What happens if the patient's so nice? Now, I haven't had this one happen to me. I have not. I've had lots of things, but not this one. Patient pulled the chest tube out.
Now you've got a hole in their chest.
Yeah, so what would you use?
Sterile.
What do we usually keep at the bedside a lot of times if you have patients with chest tubes? No, that's fine. And that you have Vaseline gauze. Lots of times you will keep that there. Here's the other thing. Let's say if we was lucky enough and just pulled that out, you've got a dressing here. Okay? But again, if they happen to rip it all out, or for some reason, just they end up with it being pulled out, that's why you use that Vaseline gauze. Open it and put it over it. It seals it so that you're as you're taking breaths, you're not giving more of a pneumothorax. Okay. And actually, patients who come back from having open heart surgery, it's in this area right here, so it's really not within the chest cavity itself. It's in the pleural space here, and it's draining. So again, it functions a little bit differently. But you always want to make sure your dressing is dry and intact. You want at least 3 of the sides sealed, not the 4th side sealed. Usually it's the bottom one. The other thing too, you want to make sure it's secured. In other words, you have this a piece of tape here, and again, if this was attached to that, you might have another piece of tape right here, so it doesn't get pulled. Okay?
Dr. Miller?
Yes.
What's the rationale for only taping 3 sides?
Because if you, it can release air the other way, rather than creating tension pneumothorax. Yeah, that's the big. We used to seal it all 4. Now we only try to leave one side, and it's usually the bottom side. And to be honest with you, it doesn't stay that well anyway. Okay.
The tube is going into the
Pleural space.
pleural space here, and that's put in during the operative procedure, during the operation.
Or for trauma, you can have it. You can put it down in the ED if they have a tension pneumothorax, if they've developed a pneumothorax or a
It
hemothorax.
can be done bedside too.
It can be done at bedside.
And then worst case scenario, the patient pulls it out and the nurse in there, you put the Vaseline gauze on it or the pressure.
Or if it's lucky enough that's got something that will seal it so it doesn't.
And then you obviously
You
yes,
ask
have
help.
to help.
Help, because your physician probably will come back and they'll evaluate and put it back in maybe. Or maybe if it's been resolved, they'll do a chest x-ray, and it might be that they won't put it back in. But again, knowing how to manage those. Okay, let me ask you this question on the patient in reference to looking at chest tubes. Could someone show me how you milk a chest tube? Milk a chest tube.
But you're not supposed to milk chest tubes.
Who tells you you're not supposed to milk chest tubes? Do you not milk a chest tube, or do you not strip a chest tube? You're right. The good part that I liked with all of you is that you knew that there was one part, something you weren't not to do. You don't strip. You milk. Okay? And let me bring this up a little higher. This is milking. Okay? If you have a clot in here, you want to milk it so you can work it down and get it down there. Because again, if you leave it in there, it's going to build up pressure, and also you're not going to be able to drain. Okay? Stripping. We used to strip. Never, ever, 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 ever strip. Never strip. And the reason is when you are doing this, you're increasing your pressure. Okay, and sometimes with open heart patients or others, you can cause sometimes more bleeding. Okay, milk, yes. Strip, no. Okay, most important. Any questions about your chest tube?
And that's just to reduce the clot or obstruction, whatever it has.
If you've got a clot in there, you got to get it out. Yeah, because it'll increase the pressure within your system, and you're not going to get any drainage. And so you want it. And then when in your milking, what you're trying to do is break that up so you can get it on down. Okay.
So if you're dealing with a pneumothorax, is it going to be up higher?
With a pneumothorax, depending on where it is. With this guy, he had a pneumothorax right here, and so they put it in. So it